Go ahead.
I'm just waiting for people to come on in, but the numbers are going up. Well, good morning, everybody. My name is Cyril Meyerowitz. I'm at the Eastman Institute in Rochester, New York. It's a great pleasure to welcome you to the third Eastman International Alliance Global Rounds. This is a process that was set in place through the collaboration of the three Eastmans across the world. We have with us people from the Eastman Dental Institute in London and people in Stockholm at the Eastman Institute in Stockholm. And today we're going to be covering a topic in periodontology. Welcome, and we're very pleased to be doing this for the third time. It's been an enjoyable round. It's also a first for us because this is the first time we're doing an all remote rounds. We'd much rather have all of you together in one place, but we were never able to do that anyhow, given that this was an international round forum. We're getting used to doing this, all of us, and it's very nice to have a very, very big participant list from all over the country, from all over the world, you could say. So let me just give you an idea of what the process looks like. We're going to have three presentations. We'll be starting off with Eastman in Rochester, then moving to Sweden, and ending with the UK. And each person will be presenting a case which will be about 20 minutes or 25 minutes, and then there'll be an opportunity for questions. But I would like all of you to please go to your screen, and if you have a question, write it at the time that you actually think about it. Don't wait for the end of the talk. I'll be collating the questions as we go along, and hopefully I'll get to as many questions as I can and present them to the speaker. So welcome again, and it's a pleasure then to welcome our first speakers. We have a presentation which is given by two people, Eliana Kotsailidi, who's a fellow in implant dentistry at Eastman Rochester, and David Fraser, who's an assistant professor. And they're going to be presenting a topic called guided implant surgery, periodontal perspectives. So go ahead, Eliana.
Well, I'll start here, and thank you for that introduction.
Oh, David, I'm sorry. I didn't realize you were starting. Well, welcome to you.
Yes, thank you. Thank you. And as you mentioned, we're going to talk about guided implant surgery and give sort of an introduction, but then really what we want to focus on is periodontal perspectives and present actually two cases that illustrate what we're referring to. So in general, guided implant surgery can be considered your implant site preparation, so your osteotomy, and then implant placement, which is directed by a guide which transfers what we call a virtual implant placement, which is when you have your implant placed in a CT scan, and it transfers that to the surgical site versus via a guiding system. So there are a few indications and advantages for guided implant surgery. Of course, one of the main advantages is that it does improve the precision and accuracy in implant placement. Another very important indication and advantage is that with proper treatment planning and use of the software, you're able to very closely coordinate your surgical and prosthetic plans. So if the implant surgeon places the implant, and then transfers the case to a restorative dentist, they will have a better chance of having a well-placed implant that can be restored easily. If done properly, guided implant surgery can also reduce the surgical time and also minimize surgical trauma. However, there are some disadvantages for guided implant surgery. There are increased treatment costs associated with the materials. You have to buy special guided implant drills in most cases. Increased planning time is required to navigate the scans, the software, to wait for the guides to be fabricated. And of course, skills are required for both incorporating this skill into your treatment planning, as well as employing it in your actual practice. So the general workflow for guided surgery starts first with determining what kind of guided surgery you would like to do. Traditionally this had been a static guidance, so you actually have a physical guide that's produced and placed in the patient's mouth. But there's also now a dynamic navigation, which can occur where you have real-time feedback from the computer system. We're not going to be talking about dynamic navigation today, but we're more focusing on the traditional static guidance. So the basis of your guided surgery really comes down to the scans. You have two main types of scans. You have your radiographic scan from your CT, your computed tomographic scan. Then you have either an intraoral scan or a scan of a model taken from an intraoral impression. These two scans are combined during the registration process. The implant is placed digitally, and then various design principles can be employed for designing the surgical guide. And then, of course, the guide is produced and used in the surgery. So just a quick note on the two kinds of scanning data. We have DICOM files, which is the file that's produced from your CT scan. And this can be used to look at two-dimensional slices showing bone and associated anatomic structures. And then it can be combined for three-dimensional rendering as well. And of course, you have your STL files, which is a surface scan, either of an intraoral site, as you can see on the right, or a surface scan of, say, a model taken from an impression. And these two are put together during the process of registration. This can be done either manually or from the computer software. But you can see that this is an important step because the accuracy of this registration will also translate on how the guide is fabricated, and in turn, how well the guide seats and is placed in the mouth. The three main categories of surgical guides, of course, you have, for your edentulous cases, you can have a mucosal supported guide. So in this case, we're doing a flapless approach. We have no mucosal flap raised. You have to do a tissue punch. The guide sits completely on the edentulous ridge, and it can have fixation screws or it can be without fixation screws. Then you'll have also a bone-supported guide for your edentulous cases. And again, this can be with or without fixation screws, but in this case, the flap is raised and the guide is seated directly on the bone. And then for partially edentulous cases, we have a tooth-supported approach where the guide rests on the existing teeth. In this case, can be done with or without a flap. It also can be done with guide screws, fixation screws, depending on the condition of the remaining teeth, the stability of the guide. So focusing in on one of the main benefits of guided implant surgery is the accuracy, or the improved accuracy that it provides versus what we call freehand, or some people refer to as brain-guided surgery. So in this case, for a static guide, you can see here in the diagram that there's sleeves placed in the static guide. And what this does is sort of places in the mesiobuccal or buccal or palatal-lingual plane where your entry point is of your osteotomy. Depending on the height of the sleeve, it also directs sort of the angulation of the osteotomy. This is important for planning how close the implant is to adjacent teeth, adjacent implants. Then when used in combination with a specialized drill system, you are also afforded depth control. So being able to precisely control the depth of your osteotomy to help locate the crestal location of your implant shoulder, and also to avoid anatomic structures such as concavities or nerves. However, guided implant surgery is not perfect. There's a limitation to the accuracy. And many studies have been done on this, comparing sort of the virtual implant placement to what happens with the actual osteotomy and implant placement. And I've just summarized some numbers from a few different systematic reviews, which are each summaries of the many studies. And all reviews show that there is a certain amount of error we must accept with guided implant surgery. So entry point deviation, sort of how far off that osteotomy is right at the entrance point in either the crest or the mucosa. We have apex deviation, which is greater than the entry point because as the farther the osteotomy progresses away from the guide sleeve, the more chance that the drill can deflect. This can also be seen as the apex deviation, or the angle deviation. And then, of course, you can have a deviation in the vertical direction. So an implant either too shallow, and this can often be seen in flapless cases where you're not able to see the location of the bone crest. Or you can have an implant placed too deep, which can become an issue if you're very close to that safety zone, say, over the inferior alveolar nerve in the mandible. So how can we take this and look at this in periodontal perspectives? Oh, sorry, I've got to getting a little ahead of myself. So first, just a quick review of some of the sources of this error. One, you can have error from your CT scan if you have a subject or a patient with a lot of existing implants or metallic restorations. You have beam hardening and scatter, and this will produce a distorted scan with limited resolution. Of course, surface scans can have error, especially if you have a intraoral impression that's taken and distorted and then poured up and then scanned. And then if these are put together, even if the scans have no error in themselves, if the registration process is not done properly, you'll have error that is sort of propagated out towards the fabrication of the guide. And once the guide is actually employed in surgery, if it's not positioned or stabilized correctly, or if it becomes loose during the process of the surgery, error will occur. When you're making a choice of how to proceed with the case, if you decide to do the case flapless without raising a flap, you will have a higher chance of having error and greater error, especially in the case of the thickness of the mucosa. In case of a flapless approach, a thicker mucosa will result in more error. Placing multiple guides, using a pilot guided case. So in the case where we only guide the first drill or the pilot drill, and then the guide is removed and the rest of the drills and implant placement is done freehand. A longer implant, so the osteotomy is done farther away from the guide, will result in more error. And of course, for anything in dentistry, your operator experience. So, a new operator will more likely to have error just from being used to or having the handle of the system. So now we'll talk a little bit about what we mean from a periodontal perspective for guided implant surgery. So I just want to take a quick step back and talk about implant success. I think we can all be aware of the idea of implant osseointegration, implant survival. The implant is placed into bone, the implant is secure, it does not move, and it accepts the restoration and the restoration functions. But nowadays, with successful implants, we have to look beyond survival and look at success. So we want implants with aesthetic success. We want patients to be happy with the appearance, both in function and, even the provider now is looking at the aesthetic outcomes. We want peri-implant health. So we want no inflammation in the soft tissues, no bleeding on probing. We want the patient to be able to perform adequate plaque control. And we want stability. We know we're going to expect some bone resorption after implant placement and restoration. We want that resorption to stabilize and not increase over time. So the literature suggests sort of certain criteria and dimensions that will contribute to this implant success. Starting with their soft tissue, the thickness of the keratinized mucosa, or the width, often referred as the gingival width, has been shown to really impact how well an implant site can maintain lack of inflammation and health. So if there's less than 2 millimeters, and especially if there's limited or no keratinized mucosa, the implant sites at increased risk for recession and for inflammation. The thickness of the tissue as well, going from the buccal surface in towards the implant, plays a role in sort of the aesthetics. If you have a thin implant soft tissue, you'll have show through of the metal structures underneath. You also have more increased risk for recession. And you can see in the example on the upper left some implants both with minimal or no keratinized mucosa and also very thin soft tissue that have already suffered from recession and show through of the metal structure underneath. And of course, underlying all of this is the bone. Studies have shown too that bone thickness of about 2 millimeters helps protect that implant from further bone loss, sort of increases the stability of the bone. We also know, of course, that the soft tissue is reflective of the bone underneath. So all of these are really interplayed. So you can see an example on the bottom left where an implant with very thin buccal bone overlaying was placed, and then subsequently significant bone loss occurred, peri-implantitis, and the flap was reflected to treat the implant. And you can notice threads showing on the buccal almost the entire length of the implant surface. So in terms of guided implant surgery, this comes down to when you're doing the treatment planning. You have your case, you have your virtual implant placement, and you're looking at your CT scan, and you're seeing how much bone is available when you place the implant in its desired position. You may see, oh, you have a millimeter, millimeter and a half, even 2 millimeters of buccal bone on that virtual implant placement. But you must realize that you're not going to have an exact placement of the implant using your surgical guide. You can expect deviations even up to a millimeter, millimeter and a half. In this case too, you're looking at your surface scans. You're seeing the position of the soft tissue. You're evaluating the patient clinically. You're looking at the patient biotype, the soft tissue biotype, to see if it's thick or thin. And then in the case you decide to do a flapless surgery, it's very important to evaluate all of these because you will have very limited chance to augment or address any findings you might happen during the implant surgery. So in many cases, it's actually beneficial to use guided implant surgery together with augmentation of the soft and hard tissue at the time of surgery to really ensure future implant success. So I'm going to turn everything over to Dr. Kotsalidi, and she's going to share 2 cases where we really put this into practice.
Thank you, Dr. Fraser. We will now take a dive into a couple of cases that were treated with guided implant placement, and we will discuss the workflow that was followed, as well as some soft and hard tissue considerations that would affect the final outcome. So the first case is a 70-year-old male that presented in the clinic with a fractured maxillary left central incisor. Both the incisors were restored with crowns and were supraerupted. An abscess was present on the buccal gingiva of the left incisor, and radiographically it was noted that the tooth had a previous root canal treatment, apical root resorption, and also the buccal bone was absent. So the fractured tooth was extracted, and at the same time, horizontal ridge augmentation was performed to compensate for the lost hard tissues. A full thickness flap was elevated, the site was carefully decorticated, particulate mineralized allograft was layered with xenograft and covered with a non-resorbable and resorbable barriers. At 3 months, the non-resorbable barrier was surgically removed and crown lengthening was performed on the contralateral right central incisor in order to achieve a gingival margin position that would be in harmony with the rest of the maxillary anterior sextant, since this tooth was supraerupted. At 6 months, almost 8 millimeters of bone were available in the horizontal direction for the implant placement. So in order to virtually plan the implant and design the surgical guide, the DICOM file that was available after the patient had a cone beam CT taken had to be merged with 2 different STL files. One STL file had the edentulous site, with the left central incisor being absent, and that's the one that would be used in order to design the surgical guide on. The other STL file had the crown in place, and that's the one that would give us all the needed restorative information in order to plan the implant position, the implant angulation, and the depth accordingly. So using the co-diagnostic software, the files were registered, and on the CBCT, you can now observe a green line representing the STL file that had the edentulous site, while with a yellow line, you can observe the STL file that had the crown on. Virtually positioning the implant, we would be able to maintain 2 millimeters of bone on the buccal of the implant in order to ensure the stability of the buccal bone over time. However, I want to bring to your attention that there was still a slight deficiency in the horizontal direction that can be mostly visualized as a flat contour rather than a convex contour on the facial of that implant. Still though, there was an inadequate bone in order to place an implant that would be approximately 4 millimeters in diameter. In order to overcome that issue, we planned for soft tissue augmentation simultaneously with a guided implant placement. Additionally, the implant was placed quite apically relative to the adjacent CJs, a little over 4 millimeters apical to the CJ of the adjacent teeth. That would ensure soft tissue thickness that would be available coronal to the implant platform in order to achieve ideal emergence profile with the final crown. Now, due to the depth of the implant placement, the sleeve of the surgical guide would have to be placed at a distance of 6 millimeters from the implant platform, and therefore, we plan to use the extra long drill for the osteotomy preparation. Now, based on this plan, the tooth-supported surgical guide was designed. The file was exported, the guide was milled, and the metal sleeve was manually inserted. At the time of the surgery, the guide was first of all tried in to confirm the proper seating. Given that we were expecting on augmenting the soft tissues on the buccal direction, buccal vertical incisions preserving the interproximal papillae were carried out. A full thickness flap was reflected, and the osteotomy was prepared through the guide using extra long drills and drill handles. With this type of surgery, we were able to control the apical coronal as well as the buccal palatal implant position. The guide was then removed and the implant was placed at the determined position in the middle of the edentulous reeds and leaving 2 millimeters of buccal bone thickness and approximately 4 millimeters apical to the adjacent CJs. Although the patient had a thick phenotype, we proceeded with soft tissue augmentation to compensate for the flat buccal contour of the reeds. So a connective tissue graft was harvested from the lateral palate and was placed on the mid-facial of the implant. The sling sutures were used to stabilize the graft. The flap was replaced and sutured with interrupted sutures. So immediately after the surgery, one would say that the site actually looked over-contoured over here. However, we were expecting shrinkage to occur during the healing period. So upon healing, the reeds had adequate soft tissue contour matching the contour of the contralateral right central incisor. Furthermore, we were able to observe that the tissue looked pink and healthy. So the final crown was installed, and you can observe the final result compared to how the patient initially started. Within the first year after the crown installation, the interproximal papilla is expected to fill in. We will now move to our second case, and this one is a little bit more complicated as it includes multiple implant placement on a 29-year-old female. The patient initially presented with multiple carious lesions, missing the maxillary central incisor, a remaining root tip, and generalized erosion. Radiographically, other than the periapical lesion on the maxillary left lateral incisor, we observed generalized short roots, mostly on the anterior teeth and the premolars. So the treatment plan for the maxillary arch included the extraction of all the maxillary anterior teeth and the premolars and restoration with implant-supported metal ceramic prosthesis supported by 5 implants. However, we decided to strategically extract some of the teeth first, place the 5 implants, and prepare the rest of the teeth to support a provisional during the osseointegration period. So our first step in this case was to digitally design and mill a tooth-supported provisional and then deliver it to the patient. This provisional prosthesis would allow to evaluate patient's aesthetics, phonetics, and function in our preparation for the final definitive prosthesis. And it would also allow us to use all that information for the implant planning. So similarly, as on the previous case, the DICOM file was merged in with 2 STL files. The first STL included the provisional prosthesis and was used in order to virtually position the implants on a prosthetically driven position so that their long axis would exit either through the cingulum at the anterior sides or the middle of the occlusal table for the premolar implants. The second STL file had the teeth at the sides where the implants would be placed removed. And that would be needed in order to design the surgical guide on, and that would fit intraorally on those teeth. So on the co-diagnostic software, the files were registered and the implants were planned on the most favorable prosthetically driven position. We could observe that the buccal bone on the maxillary right central incisor and the maxillary left canine was very thin and measured almost less than a millimeter. That would mean potential unpredictable buccal bone loss over time. In order to overcome that issue, we plan to perform horizontal bone augmentation at the time of the implant placement on the facial of these 2 implants. Now, according to that plan, the tooth-supported guide was designed and printed. In this case, the guidance would be partial, meaning that only the surgical template would be used only for pilot guidance, except for the anterior osteotomy, where all the drills would be used through the surgical guide. The reason why we decided to do so is because of the complexity of this case in terms of bone availability and the multiple implants that needed to be placed. At the time of the surgery, a full thickness flap was elevated on the facial, given that we had already planned for simultaneous bone grafting. The hopeless teeth at the sites where the implants would be placed were extracted, and the guide was tried in, and the seating was confirmed. The pilot drills were used through the guide for all the osteotomies, but only for the anterior osteotomy, the drill handle and the extra long surgical drills were used through the surgical template. The guide was then removed, the osteotomies were finalized, and the implants were placed. So, as mentioned before, the implants on the right central incisor and the left canine sides had very thin buccal bone. So the sandwich bone augmentation technique was used in order to horizontally augment the buccal bone. Upon careful decortication of the sites, autogenous bone was harvested from the adjacent sites and placed as a first layer over the native buccal bone and topped with xenograft. That way we were able to combine the osteogenic properties of the autogenous material and also the space maintaining properties of the xenograft material. A resorbable collagen barrier was used to stabilize the bone graft, and that was fixated with fixation pins at its apical and palatal ends. With the use of periosteal releasing incision, the buccal flap was coronally advanced and primary closure was achieved. This case is still under progress. The next step will be to uncover the implants after the osseointegration period is over, extract the remaining hopeless teeth, and that's namely the canines and the premolars, and proceed with the installation of an implant-supported provisional prosthesis. So guided implant surgery using 3D implant planning has opened new horizons for a multidisciplinary, restoratively and surgically driven treatment approach. In clinical practice, there are certain situations that definitely call for guided implant surgery in order to achieve increased accuracy and precision for the implant position. Yet, the critical factors for long-term implant success still remain the proper diagnosis and case selection, the care, skill, and judgment of the clinician, adherence to surgical and prosthetic principles that take into account hard and soft tissues as well as vital anatomic structures, good communication between the implant surgeon and the restorative dentist, and last but not least, patient awareness, education, and compliance. So with that, and on behalf of the Department of Periodontology at the Eastman Dental Center in Rochester, New York, we want to thank you for your attention, and we are ready to take any questions that you may have.
Okay, thank you very much for an excellent presentation, David and Eliana. We have 3 questions that came through. We've got a little bit of time, not too much, but let me just give them quickly. I think David's answered one already online, but if you could just go back to them, one, David, which is what virtual planning programs are being used. If you could just answer that very quickly, we can move to the other 2.
Sure. So in this case, for the virtual implant placement, it's Anatomage is the name of the software being used. And then I think that was chosen in case because that's what we use in the clinic here at Eastman in Rochester. Of course, there's many other different kinds of software. There's even open source where you don't have to pay for the virtual implant placement. I don't think there's been any studies showing one is more accurate than the other. I think it comes down to user preference.
Okay, thank you, David. That was good and short. So we have time to move on to the next one. How do you get rid of the black triangle between the incisors? A question that's always asked.
I think I can try to answer that one very quickly as well it's very complex. It's a complex question. The short answer is once you have a black triangle between incisors, whether implant or teeth, it's very difficult to fill that with soft tissue. Most surgical approaches are not successful. it really comes down to treatment planning and placing the implant before. If you have no black triangle to start with, you have a better chance. If you're extracting a tooth that already has a black triangle around it, you most likely will have a black triangle afterwards. So I'm sorry, I can't go more into that, but that's a whole hour-plus-hour-long series of talks on its own.
A complicated question.
Yeah.
Okay, and the last one very quickly is it possible to determine the accuracy of the surgical guide before placing the implants? I'm not sure I quite understand that question, but perhaps you could comment on that.
Dr. Kotzalidi, do you have anything to add to that?
Thank you. So one thing that you can do in order to is to confirm that the guide is sitting on the cast that you have and basically represents the situation in the mouth at the time of the surgery. Now, other than that, you can also take another CBCT potentially with a guide in mouth and radiographic markers at the sites where the osteotomy is going to be prepared. However, unless you place the implants, you cannot confirm how accurate you are in terms of the angular deviation and the depth deviation. The only way to do that would be after the surgery, taking a CBCT and comparing it with the virtual implant placement.
Okay, good. Thank you very much. You know, we just have a minute, but in order to provide some input from the other panelists, let me at least just open very, very quickly for any comments from Sweden and the UK. Professor Diuto or Dr. Modin, any comments or any questions?
I'm not going to make I'm not going to make a comment about the black triangles, otherwise we'll never stop the discussion. I think very nice presentation from Eastman in Rochester. My question is, how do you feel this guided approach will be translatable in practice on a regular basis?
Thank you. Good question.
I think we find that it's very translatable depending on the clinician. You know, many periodontists in the U.S. at least have a cone beam CT already in their practice, and many are actually developing their own in-house labs, milling equipment as well. So it really depends, you know, upon your the patient, the clinician perspective. But we found it's very translatable. Even so, more the computer guided, some clinicians are starting to have that in there. So one of the reasons we actually teach and encourage the residents to become familiar with the system in residency is that we find that many of the providers, or if they say they work for another periodontist in practice, will be using that. So once you work it into the workflow, it becomes very translatable.
Okay, good. Thank you. We're only 2 minutes late, which I think is good. And I want to introduce our next speaker. Very good presentation. Thank you, David and Eliana. Our next speaker is from the Eastman Institute in Sweden, in Stockholm. And we have two people who prepared the presentation. I believe only one is presenting, but Carolina Modin, who is a specialist in periodontology, is going to be presenting. She worked with the gentleman next to her, Elias Yayu. So thank you, Carolina. If you go ahead and share your screen, we could go ahead. Thank you.
So, do you see it here?
Yes, it looks good. You're right online and it's on the screen. Thank you very much, Carolina.
So, thank you. Hello, everybody. So nice to be part of this Eastman Global Rounds. And my name is Carolina Modin, and I'm one of the specialists in periodontics here at Eastman Stockholm. I'm the speaker for today, but I've got great help from my colleague Elias Yayu with this presentation, and Elias is with me here today. I'm going to present a multidisciplinary case for you, a journey that started 4 years ago. This 12-year boy I first met in June 2016. He was referred from his general practitioner due to intractable pockets in combination with swelling and pain, and with the question aggressive periodontitis. His problem was recurrent tenderness, pain and swelling in the region of 3.3 to 4.1 the past 6 months. The week before he came to me, the problems had become worse. He got fever and a more pronounced swelling around 3.3 and 3.2. The dentist prescribed penicillin, but due to sublingual mouth swelling and some respiratory difficulties, he went into the emergency care at the hospital. The ENT doctors found no swelling in the throat or clear diagnosis, but they prescribed metronidazole in combination with penicillin. His mother stated that the boy was otherwise healthy and had no allergies or medications. She also mentioned that the boy had a slow healing wound on the lower lip 6 months ago. The specific case history gave me that he had had an extra oral swelling at the left bucca for approximately 4 weeks and also pain and swelling from the region 3.3 to 3.2. The teeth 1.3, 3.3, 3.2 had high degree of mobility. He thinks the symptoms now are a little better after starting with the penicillin. There are deep pockets with bleeding and pus at 3.2 and 3.3 and deep pockets at 1.3 without pus. Intraorally, I can see swelling in the surrounding mucosa at 3.2 and 3.3. He has a mixed dentition with no fillings, but lots of plaque and a supragingival calculus. My periodontal examination shows the deep pockets between that's between 6 and 11 millimeters with bleeding and probing, with bleeding and probing and pus at this region here. And at region 1.3, there are 6 millimeters pockets around, but no bleeding or pus. Here we can see the panoramic radiograph. And as you can see, the bone support looks normal around the first molars and the incisors, which are the teeth that almost always are the ones that are affected when you think of aggressive periodontitis. The intraoral radiographs showed open apices in the region of 1.3 and 3.3. And here we can see some horizontal bone loss, and mesially to 1.3 we can see some radiolucency. My knowledge and experience tells me that this doesn't look like an aggressive periodontitis, but what is the cause of the problem? At this time, my goal of the therapy is to achieve the reduced swelling and pain, determine the diagnosis and proper treatment. I discussed with a colleague and we decided to prescribe amoxicillin, a more broad spectrum penicillin than the one he got before. A bacterial sampling was taken from the pockets around 3.2 and 3.3. We give him oral hygiene instructions and tell the mother to seek further medical investigation by the pediatrician. I consult pest specialists in oral radiology and maxillofacial surgery. And here we can see the results from the microbial sampling, and it did not indicate elevated levels of the usual periodontal pathogens. After I met him, the mother took the boy to the nearby health center, and this was the result from the blood sampling. I discussed with the physician who told me this is almost a normal result, but anyway, she referred the boy to a specialist clinic for further immunological investigation. The physician also mentioned the slow healing wound on the lower lip he had had during the winter. And here, the marked numbers here, and here, they are the numbers that are outside the reference interval, and they indicate that he has gone through an infection. 8 days after my first investigation, I see the boy again. Now he feels much better and has no pain. Clinically, there is still swelling in the region of 3.3 and 3.2, but less pronounced, and the pockets around the teeth are not as deep as before, except 3.3 distally. After I've been discussing with the maxillofacial surgeon colleagues, he is now referred to the specialist in radiology at Eastman for a CBCT. And briefly, the radiology report says this. There's a perioradicular destruction around both 1.3 and 3.3. There is a irregularity at 1.3 on the mesiopalatal aspect. Maybe it's an external root resorption. There's a periosteal apposition at the buccal aspect of 3.3. And 3.3 mesiolingual, there's a bone sequestrum, size 5 × 2 × 1. And there's some diagnostic suggestions. Multifocal osteomyelitis, Langerhans cell histiocytosis, neoplasia, and they are suggesting that we might take in biopsy. And here we can see the CBCT around 1.3, and this is little, see if you can see it here. And on this one, we can see clearly the periradicular resorption. And this one is in another view, how it looks like here around the tooth 1.3. And here we have the tooth 3.3. And it has a typical apposition here and periradical radiolucency around the whole tooth. At the end of June, I see him again, and now he's feeling quite normal, no pain or other problems. Tooth 1.3 shows no mobility, but 3.3 and 3.2 still have mobility degree 2 and deep pockets. There is almost no swelling left. I discussed with my colleagues again at the maxillofacial department, and we agree that this is not periodontitis. The radiology report gave us several suggestions that has to be gone through. And in August, I see him again, and now he's feeling totally well. He has been to a physician at the hospital, and they found nothing that can explain his earlier oral problems. And the periodontal status shows 5 millimeters pockets around 1.3 and 4 to 8 millimeters pockets around 3.3, and the tooth is mobile degree 1. And here we can see the photos from the initial examination and 2 months later in August. And here is the radiographs here from the first visit in June, and here we have them in August. And now we can clearly see there's root resorption at tooth 3.2. We now have some tentative diagnosis: osteomyelitis, Langerhans cell histiocytosis, neoplasia, and root resorption of 3.2. The maxillofacial surgeon colleagues decide to make an exploratory surgery for verifying the diagnosis of osteomyelitis and exclude any neoplasia. And the outcome of the exploratory surgery is that no biopsy was harvested due to no findings of neoplasia or acute or active osteomyelitis. But clinical appearance did indicate chronic osteomyelitis because the bone buccal to 3.3 was thickened, which is often seen in the osteomyelitis patients. And from now on, the patient is handled by the maxillofacial surgeon teams at Eastman, and they are planning for checkups. Our department managed the periodontal supportive care. He still has difficulties with achieving a proper oral hygiene, and I see him for a checkup in February 2017. And compared to baseline, periodontal status now is almost normal, except 3.3 distally. The biggest problem for him now is the gingival retraction, buccal to 3.3, that is the result after the surgery. And here we can see the intraoral radiographs from February in 2017. In September 2017, a new CBCT is done 1 year after the first one as a control. And the radio, briefly, the report says like this, that it's a normal bone structure around 1.3 now. Clearly, we can see a root resorption at 1,3 at the ECG with communication to the pulp. The bone resorption buccal to 3,3. There is a bone resorption buccal to 3,3 that's approximately 2/3 of the root length. And the bone structure is normal now. But they also can see root resorptions at both 3,1, 3,2, and 3,3. And here we can see the CBCT again. This is 1,3. And I will try to stop there. Here you can see the resorption with the communication to the pulp. Like that. And here we have, now we are in the region of 3,2 to 3,3, and we can see the, let me see, I will try to back there. Here we can see the resorption here and how much bone support he has lost. And this is 3,3 from another view, and 3,2, and here we clearly can see the root resorptions of 3,2. And after a while, even we can see 3,1. Okay, due to the root resorptions, now he is referred to the endodontic department. 1,3, 4,1, 3,1, 3,3, all are responding to vitality tests with both cold and electricity, but not 3,2. So 3,2 is necrotic, and endodontic treatment is done in the end of 2017 and beginning of 2018. In February 2018, I see this patient again for a last checkup, and he is referred back to his referring dentist and dental hygienist for future supportive periodontal treatment, but continuous controls will be done at the maxillofacial and endodontic department. The prognosis for both 1,3 and 3,3, 3,2 is poor in the long perspective due to the root resorptions. The case is discussed at a multidisciplinary meeting at Eastman. 1,3 will be kept as long as possible as 3,3 and 3,2. But already in the summer of 2018, he is referred back to me from his ordinary dentist due to pain from the region of 3,2 and 3,3. No swelling extraorally or intraorally, but pain, and 3,3 are more mobile again, now degree 2. Pockets as before. The tooth is grinded and adjusted occlusally due to dramatic occlusion. But I see him again after a couple of days to see how he's feeling, and the problem is getting much worse and have much deeper pockets and now severe pain. Here we can see the intraoral radiograph, and the bone support is looking worse now around in this region. He obviously got a relapse of osteomyelitis, and penicillin and metronidazole once again are prescribed. This time for a longer period, up to a month. I see him a month later, and now he's feeling fine again, so the antibiotics have helped him this time as well. No pain in the region, and the pockets are again between 5 and 6 millimeters. But the patient is once again discussed at a multidisciplinary meeting, and the diagnosis, Langerhans cell histiocytosis, is coming up again, both due to the root resorptions, and the maxillofacial surgeon colleagues are uncertain if the investigation about the disease really is done. We also discuss extraction of 3,3. Maybe the bacteria in the pockets can initiate the osteomyelitis. Consensus is anyway that we will keep 3,3. It's not easy to replace it right now, and we want to see what happens to the neighboring teeth in the future. He is referred by one of the maxillofacial surgeon to the physician, and he meets an oncologist at the Children's Hospital here in Stockholm. And the outcome of the investigation by the oncologist is that Langerhans cell histiocytosis is not confirmed. No other malignant diagnosis could either be confirmed. Vitamin D deficiency could be confirmed though. Blood sampling showed no other deficiencies. So the therapy plan is as before: controls and continuous care by the maxillofacial department, and controls every 6 months by the endodontist regarding the root resorptions, and the supportive periodontal treatment will continuously be at the referring clinic. In November 2019, he met the endodontist for a checkup again. The root resorption of 3-3 buccally were growing, and decision was made to treat it. So in January this year, the resorption were treated during surgery, and the resorption was unfortunately deep with a small pulp lesion that you can see. This is the mirror, and here you can see the pulp lesion, and it was repaired with MTA. And in fact, this was the latest visit he had here at Eastman, but for sure not the last one. Some concluding remarks about the therapy. Bacterial and blood sampling, physiological investigations to find a proper diagnosis and to exclude differential diagnosis was made. Periodontal treatment to improve infection control, exploratory surgery at the region of 3-1 and 3-3, and endodontic treatment of 3-2, as well as sealing of root resorption at 3-3 buccally. The patient's infection control was constantly poor. Throughout the treatment period, the patient has had 1 relapse of osteomyelitis. The patient is overall satisfied with the treatment and not concerned by the status of 3-2 and 3-3. The long-term prognosis of 3-2 and 3-3 is bad, and for 1-3 it is questionable. The future, the patient is undergoing supportive periodontal treatment every 4th month at the referring clinic, while still being monitored at the maxillofacial and endodontic departments. And some concluding remarks about osteomyelitis. In the literature, there is various classifications with different names. At Eastman, the classification, we have this kind of classification now. We have acute osteomyelitis, secondary chronic osteomyelitis, or primary chronic osteomyelitis. The primary chronic osteomyelitis, typically for that is the periosteal thickening and subperiosteal new bone formation or root resorption. And the subgroup of this osteomyelitis is the one that's called the chronic recurrent multifocal osteomyelitis, that's most affecting children and adolescents. And that is kind of we think this is an autoinflammatory bone disorder. What this boy had, we have called it osteomyelitis the whole time, but obviously he had osteomyelitis in the beginning that became a more chronic one. The prevalence, 8 of 100,000 children per year in high-income countries develops osteomyelitis. And in the low-income countries, it is more common. Boys are affected twice as often as girls. About the etiology, when osteomyelitis is in the mandible or in the maxilla, you often can see it can be an apical periodontitis or an erupting tooth, pericoronitis, trauma, fractures, or hematogenous seeding. In this case, we think that the erupting 3-3 in combination with plaque can be the cause. And maybe the slow healing wound he had on his lower lip had something to do about it as well. When it comes to treatment, antibiotics and anti-inflammatory drugs is the first choice, but also biopsy and sometimes corticosteroids and surgery like decortication has to be done. And it's important to see what kind of differential diagnosis you have. So you have to see there's no neoplasia like Ewing sarcoma or Langerhans-Sells histiocytosis. Here we have the reference list if someone is interested, and but otherwise I say thank you for your attention.
Thank you very much, Carolina and Elias. A very, very nice, interesting presentation and complex one as well. We have two questions. One is from an orthodontist. So this is a multidisciplinary case. So let me give you that question first. It is the following. Would moving the 3-3 root into bone facilitate the healing process, taking into consideration the periodontal care seems to be controlled, as both 32 and 33 are affected by the buccal position of 33. So Dr. Rousseau in Rochester, who's the chair of the Department of Orthodontics, is asking an orthodontic question related to the use of ortho in the multidisciplinary case.
Well, as a periodontist, he is not, I mean, he has deep pockets. His oral hygiene is quite poor, we would say. So to put on an orthodontic treatment, I think it would make it worse for these teeth, so they will be lost earlier than we want. What do you say, Elias?
Yeah, I agree.
So
Okay,
we don't think orthodontic treatment is a way to save these teeth with a better prognosis.
Okay, I appreciate the response. Unfortunately, we can't have an interactive thing, but if any other panelists want to comment on their question, then we could just take that a little further. If not, we can move to the next one.
No, I think it's an interesting comment from the orthodontist, but I cannot agree more with Carolina and Elias. For me, this case obviously underlines the inability for us to know what risk that site will have, especially in the worst conditions. So it's very difficult to imagine. You could suggest predictably orthodontic treatment will help.
Okay, thank you very much, Francisco. Our next question is actually from an oral medicine person, or the chair of oral medicine, who says in Rochester, who says the key to is to make the diagnosis. What about differential diagnosis of vanishing bone disease?
If you mean if we had any other differential diagnosis?
Yes, I guess the question was the suggestion is a differential diagnosis of vanishing bone disease. I actually, if the questionnaire could just expand on that in the question and answer period, then maybe she could expand on that particular diagnosis.
I don't know what diagnosis you said. I didn't hear what.
It's called vanishing bone disease.
Vanishing bone disease.
Yeah.
Well, we haven't. That's nothing that we have been looking at. I know now the case now is handling with the maxillofacial surgeon department, but I have a lot of discussion with them, and this is nothing that they have been discussing. So no, there's nothing. He has not been investigated for that.
Okay.
That's
okay. Thank you. I'll await maybe an expansion of that question, but in the meantime, we have a question. Could the vitamin D deficiency be associated with the case? Or what is the impact of the vitamin D deficiency?
No, we don't think it has anything to do with it. It was just, that was the only thing they found when he went to the oncologist and they did investigation there. That's what the only thing that was not normal. That was the vitamin D deficiency. Then he's quite short, this boy. So they have been discussing if it had something to do with that, but they don't think it has something to do with the osteomyelitis.
Okay, good. Thank you. Let me just expand on the question that came about vanishing bone disease. Just Dr. Allah did provide us an expansion. She says vanishing bone disease is a rare disease of unknown etiology, which is characterized by progressive replacement of bone framework by proliferation of endothelial-lined lymphatic vessels, may manifest in bone lysis and root resorption, and she says more in the literature. So an interesting addition to the differential diagnosis.
Yeah, we take that with us and talk with my colleagues. Thank you.
Okay, great. Thank you, Dr. Lund. Any other comments from the panelists? I believe we have just a couple of minutes. Any other comments or questions from the panelists or from the other speakers? Okay, hearing none, let's continue. Very, very interesting presentation. Thank you very much, Carolina and Elias.
Thank you.
Our next, so if you could just, yes, our next presenter is from the Eastman Dental Institute in London. It's Professor Francesca De Juto. Professor De Juto is the chair and the head or honorary consultant of periodontology and restorative dental sciences. He's going to be giving a presentation on a challenging case of generalized gingival recession. Let me just remind everybody before he starts that if you have a question, do it on the question and answer tab. And remember, at the end of this presentation, there will be an opportunity to complete a poll for continuing education credits. Thank you, Francesca.
Thank you very much, Sirius. I hope that everything is showing up okay, and my sound also is okay.
Yes, it's good, and the sound is good. Thank you.
Fantastic. So what a pleasure to be part of these rounds and seeing from the other instruments around the world a variety of cases and expertises. I've discussed with our team here in London and the UK, and I'm in depth with one of our past graduates and now colleague, Dr. Lim, who helped me put together instead a presentation of managing a case that we work together connected to one, let's say not necessarily called a disease as such, but one common feature periodontists will tend to face at some point in their career, which is managing recession. We heard about black triangles earlier on. Here we're probably going to see a little bit more complex case. So I'm going to walk you through as I would into the case, and I'll probably take some pauses and leave some open questions for anyone who then wants to send any questions or maybe start a stimulating discussion, because as usual, there's never a single way of managing a case. So we are here a 31-year-old female case that was referred to us with a specific reason. From the dentist's point of view, as you can see from the slide, it was clear that the main question was managing the gingival recession. And when asked specifically from her point of view, the patient itself clearly had a particular impact of that gingival recession from an aesthetic point of view. I don't like the look of my receding gums, but also without prompting, which is for those of you obviously that understand why I'm making that comment, without prompting, she's also mentioning about sensitivity, so root sensitivity or teeth sensitivity in generalized fashion. So from the general medical history point of view, the patient did not report any medical conditions with no known allergies. So the risk profile seems to be quite simple, and never smokers with average level of stress. I would say probably an average 31-year-old patient. But clearly when asked about history of previous orthodontic treatment, she mentioned that that was specific. She had already undergone 2 courses of conventional orthodontics previously. And her sensitivity, if you look at the specific case history, tended to be focusing in one area at points, which was the lower left canine, but also in areas we would normally already, even before looking at the case, imagine to be connected with gingival recessions and factors causing the recession. She came in also undergoing a 3rd course of orthodontic treatment, so she probably was quite concerned about aesthetics on the starts, having undergone already 2 traditional orthodontic treatment courses and now an Invisalign type of course of treatment. And in fact, if you start to see let's say, I wouldn't call it necessarily spontaneous smile, but definitely a smile from a patient to let us understand straight away what was the impact of the recessions. You can see from an external point of view, a medium to high line with clear generalized recessions, in particular affecting the upper dentition, both the right side and some of the left side. There's always also that you can see in these initial presentations, not just the buccal composite texture connected with obviously an Invisalign treatment, but potentially also some components of trauma, and therefore without the lack of any loss of teeth structure, tooth structure, most probably some sort of composite also in those areas. If you now look at the intraoral status in terms of images, we can see both focusing primarily on the occlusal sides first. So we can see that she's still ongoing. So as she came in, she was undergoing her Invisalign treatment with still a little bit of non-alignment on the upper and onto the lower dentitions. Whilst it's quite striking, and that's where we'll focus a little bit more of the presentations of her periodontium as we're looking at the anterior and the premolar molar sides. So we now focus a little bit more in this area, trying to describe it. It's quite obvious that we are facing a case with a thin gingival phenotype and pockets of localized inflammation. So despite obviously with the limitations of presentations and graphics, you can see that the tissues seems to be clinically healthy, with the exception of some areas, which will focus a little bit more, but in particular the lower left canine, as she pointed it out earlier, she was the one with the greatest sensitivity. It's probably the tooth with also the greatest amount of local inflammation. If we look at the presence or absence of keratinized tissues, again, the thin bite of the tissue clearly goes well with the lack of keratinized mucosa in a number of sites, but in particular quite obvious in the lower anterior areas where some pockets of keratinization still present on the upper arch. If we just focus on the hard tissues of the tooth structures, they obvious, in addition, obviously, I'm not going to touch upon the Invisalign buccal composites, but there are a variety of composites present on some of the upper canines, premolars on either sides. And I will just point you that the non-carious tooth surface loss is obviously was quite obvious on the occlusal surfaces images, both on the upper and lower, and it's connected to a variety of parafunctional activity and in connection with the orthodontic treatment. And you can see there yourself the type of occlusion the patient has. So the complexity and the difficulties in this case, obviously, when you have in front of you a patient complaining about aesthetics and sensitivity, obviously from the periodontal perspective, already creates a number of questions in how am I going to manage both effectively, and whether I do have in my hands any predictable treatment options that would allow me to do so. And what stages this treatment, or how will I stage my treatment in an effective way without affecting the patient's long-term management. So the closer occlusal, frontal view is there to highlight in particular the difficulties of patients of maintaining great oral hygiene at the site. Whereas if we then looked at the other sides, you can clearly see not just the lack of the keratinized tissue, but the addition from previous colleagues of composites in some areas, most probably to try and compensate for both the aesthetic compromise and at the same time the sensitivity of the patient was affected. So if we look instead at more clinical evaluation of the case and quantification of the recession, so this 6 points probing pocket chart is such that firstly represent on my left list the level of plaque, if at all, in the mouth of the case, and gingival bleeding upon probing, which you can both agree for me is, I'd say, average and surprisingly low in terms of the bleeding, particularly plaque. So patients that already has a reasonable level of plaque control, And on the other side, instead, the aggregate measures will be the number of periodontal pockets that, for instance, and here presented in percentages, have different thresholds, equal greater than 6, equal greater than 4, or less than 4 millimeters. Again, highlighting the fact that for the exception of some 1 or 2 localized deeper or slightly deeper periodontal pockets, the case is lacking any signs of particular complex periodontal diseases, so periodontitis as such. The recession instead seems to be focused primarily or affecting the upper right sides greater than the left. So we're not going to go into details of the amounts of the graded recession, but it's ranging between 3 and 5 millimeters for the upper. And if we look at the lower presentations, which is where we have the lower left canine with the greatest amount of recession, the range of 7 millimeters, again, we can see how it's particularly generalized in the lower anterior section, with some loss of attachment also in relation to the interproximal soft tissue, which then creates the increased amount of complexity the moment we are starting to imagine what options of treatment we have and how do we bind into our patients in understanding what we could get and what will it take to get to that goal. An intra-oral radiographic status to confirm any presence of either excessive bone loss or any other untoward findings highlight quite clearly that if it wasn't for some mild horizontal bone loss in particular present in the lower anterior sides and the presence of the widened periodontal ligament spaces in connection with obviously the ongoing Invisalign treatment that the patient presented with, it's quite inconclusive with no other major radiographics findings, which gives us a list, the basis for defining our treatment plan, understanding that the previous courses of orthodontic treatment might definitely have been one of the most important predisposing factors, maybe, for the positioning of the teeth in relation to a constitutional thin gingival phenotype. There are some probably shortening of root lengths as well, which explain some of the historical findings the patients have. So going through the diagnostic status, we obviously classify the gingival recession defects according to the latest classification with gingival health but unreduced periodontium, to which we added diagnosis of dentine hypersensitivity and the presence of tooth surface loss from uncalous lesions in relation to both erosion and attrition on the occlusal surfaces, so in relation to possible parafunctional activity, but as a consequence of the presence of composites, most probably also in connection to abrasions to incorrect brushing technique. So if we then to summarize from a patient perspective in our objective point of view with our initial goals of therapy, the patient's main complaints remained the recessions of gum tissue in association with both the sensitivity, particularly for the lower left 3, and the poor appearance. That's obviously matched quite well the presence of an objective generalized gingival recessions, some localized areas of inflammation, and a generalized status of tooth surface loss, which made us to define numbers of goals for managing the case of addressing the patient's concerns, particularly the sensitivity, reduce obviously the potential risk of future further gingival recession or tooth surface loss, with the aim of improving aesthetics to be, as you can see probably in the sequence, as an important aspect to take into account, but not as the primary goal to start. Using a sort of a recognized classifications for prognosis, you might recognize some of the orders there. We defined the whole dentitions having a favorable prognosis, taking into account the existing level of attachment, bone loss, the lack of any diagnosis of chronic conditions. So across the 3 phases of treatment that we defined as part of our initial therapy phase, we discussed at length with the patients. In particular, the case included an important discussion and setting of some realistic goals. The moment, obviously, the patients completed their orthodontic treatment, so the Invisalign, and the phase of treatment would have included sessions of non-surgical treatment for improving our hygiene, although we started already from a good starting point. and see whether we could achieve a better stable gingival conditions in areas where the patients were struggling. A diet and analysis and advice for using the sensitizing agents, particularly fluoride on one side, and managing the sensitivity with a variety of topical products or advices in relation to diet, was also part of these initial treatments, to which we then waited slightly longer than the usual couple of months to assess if this initial therapy approach would have managed at least the sensitivity of the patients. And at the reassessment, within that first hurdle, we could see clearly not that big change in relation to the recessions. We're happy to see the patients had completed, obviously, their third course of orthodontic treatment with fixed upper and lower retainers. And with regards to the gingival health, there is definitely an improvement. So a very motivated patient and compliant, as you can see already on the left in the canine region, where it would be quite difficult to manage plaque control for a number of reasons: sensitivity, the difficulty, the unevenness of the gingival margin, etc. The patient is doing a reasonable job with some already change of, I wouldn't call it keratinization, but definitely change of quality of tissue surrounding the area of recession. And that is where obviously the discussion goes more into the details, where we now reevaluate the case and identify that indeed what we see at this assessment is a stable periodontal status, at least from an inflammatory point of view. If we focus for a moment on the level of plaque, you can see how ideal this type of cases might well be, because we can manage even a further reduction of the level of etiological factors with a plaque score of 17% and a great reduction, obviously, of gingival bleeding and the almost complete absence of any other liver periodontal pockets or moderate to deep. The gingival recession seems to be, again, still a focus without deteriorating much. And for those, obviously, that approach gingival recession, you do know how risky for patients following your advice and finding out that after your initial course of therapy, the gingival is actually deteriorating, because some components of the gingival tissue will tend to disappear. In this particular case would be the gingival swelling. But we're still within a range of 3 to 6 millimeter gingival recessions, which tend to be, again, with this maximum component in the lower left canine region and the lack of keratinized tissue in a number of sites. As our diagnosis at this stage won't change, with the exception that the sensitivity advice and approaches we put in place were sufficient for the patient to maintain a reasonable quality of lifestyle without having to change completely, because the sensitivity was managed. We left ourselves, therefore, discussing what options we have at this stage for managing the aesthetics. And is that realistic to imagine that we can restore completely the periodontal tissue lost, even following the combinations of positioning of teeth, orthodontic movement, thin gingival phenotype? So in this case, the options discussed with the patients were mostly in relation to how can we mitigate the aesthetic compromise for a young patient who's clearly very concerned about it, and would that treatment approach reach a complete resolution? Unlikely. And how would then our treatment at least manage the future risk for the patients to lose any further gingival tissue itself? And that is why in our corrective therapy phase, we discussed a variety of treatment. And this would obviously be the point of discussions of any periodontist that is listening out there, of what options will we go for. And obviously with the underlying basis of maintaining good oral hygiene and maintaining a healthy gingival tissue throughout, a variety of options and surgical procedures could be employed at this stage. Some with more or less invasiveness or morbidity, as we define it for the patient itself, but also with a different predictability. So obviously with the lack of keratinized tissue, particularly greater in the lower anterior region, which was the region with the greatest amount of gingival recession, then the most predictable options, which was the adoption of a free gingival graft procedures, basically translation of keratinized tissue in the region, was discussed. Obviously, the patients had to buy into the invasiveness of the procedure itself and the extent as a procedure. And at the same time, the other areas of gingival recessions where there was potentially some residual level of keratinized tissue, but more in an aesthetic side, then the options of redesigning or redefining the enamel structures on teeth that had received composite restorations was discussed, with the implications of increased sensitivity, most probably in some of the areas, or at least a temporary increase of sensitivity, but removal of, or let's say adaptation of those existing composites, or redoing those who didn't have any value they maintained, was discussed within the context then of performing a coronary advanced flap procedures to advance all the upper gingival tissues in combinations with the connective tissue grafts, which we know by the evidence at this stage would have increased our predictability to maintain the gingival level as high as possible to the new or the established synaminal junctions, and that as opposed to alternative treatment options, which would have been potentially just a coronary advanced flap without the need of a palatal additional grafts, or alternative options which have been potentially less invasive and more conservative tunneling procedures. Now, the patients had, at this stage, obviously understood most of the procedure itself, but clearly you can see that some of these procedures, as they were planned, were quite extensive, involving one side to the other. And the last of the 3 surgical procedures that we agreed with the patient to go for was performing, after having increased the amount of keratinized tissue in the lower dentition, an advancement of those newly created tissues. At the points we were sure that we had maintained at least 3 millimeters of keratinized tissue, and with the advancement potentially consider an alternative equivalent, or at the moment there is insufficient evidence to suggest it's either superior or inferior, an equivalent technique of advancing gingival tissue but using enamel matrix derivatives, and then performing a final reassessment within 6 months of the treatment. So we're going to fairly quickly, as you know, this is always a matter of debate on the technique of procedures, but clearly we are for increasing the amount of keratinized tissue. So gingival grafts, which is one of the oldest, probably neogingival corrective procedures, has been defined and described in a variety of methods. This one was performed on a large and extensive bed, taking into account that our upper limit was probably the gingival margin where the recession was, and uneven already definitions, as you can see, that will probably already open for potential residual recession at some sites. And a very extensive gingival graft harvesting from the palatal sides, which was then maximized, a palatal graft which had also included the tuberosity area, and then with some small incision extended in order to cover the whole recipient bed, which is then shown in the next slides, the reposition sutured and maintained, with also an enlargement of the vestibulum area and some retaining suture in order to slow down the creeping of the mucosal tissue. And for the institutions, you can see the first initial review of the surgery with patients wearing the classic, now new retainers. Actually, probably after the 3rd course or after we want to not go back again to their road, and an initial fairly recent healing with keratinized tissue already present overall. But as you can see, residual recessions and some classical inflammation recent in relation to the surgery in areas that we would have expected. Moving on to the upper sides, as you can see, our decision making was to use maximize obviously the palatal sides, minimize the number of surgeries, but at the same time having patients buying into the idea of more invasive procedure, but less in numbers, etc. So as the lower initial physical graft was set as a single procedure, the same was for the upper right and upper left procedures, which had been preceded by the removal of the composites. And that's where the addition of new composite material was defined with an increase of sensitivity, but a better and a more harmonic CEJ contour, combined instead with a classical multiple gingival recession, coronal advanced flap, using techniques that have now been sort of debated from the Italian group of Zucchelli and DeSantis over the years, which included a number of incisions that would allow us to predict the type of advancement that the tissue will have if we then advance onto the recession sides. But sparing, though, in our plan, the interincisal papilla, which clearly did not seem to have particular site of recession, and to minimize risks for complications, we maintain and intact with obviously a tunneling procedures to try and obtain initially, as you can see here from the flap elevation, the preparation of the side bed, the papilla starting to be prepared from anatomical to surgical, following which we have the harvesting from the other side of the palate. So as you can see, we've tried therefore to maximize in the two procedures and minimize the impact in areas that would otherwise would have been healing or with poor quality tissue. The harvesting of another graft, in this case, although harvested in a free gingival graft feature, was then desepithelialized, involving both hard palate and part of the tuberosity. Was then designed to create two connective tissue grafts, which were used in the two areas of the sessions, both on the right and the left side. And this is the advancement, which is probably the most crucial aspect of the surgical procedure, beyond the CJ on a passive nature, to try and reposition as high as possible the new gingival margin, which obviously will be creeping up and readjust at a higher level, as you can see 2 weeks later. That was the healing with the classical corrected staining, but an initial decent clinical finding. And the last procedures the patients underwent was, as mentioned before, with the aim of achieving a greater coverage of roots to minimize possible future sensitivity or ease the ability to clean. And now that she had seen obviously how the upper gingival recession could be managed, she also wanted to see what could be achieved on the lower. And so in this case, a multiple gingival recession flap was designed, but rather than harvesting any other grafts, we used a applications of gel, and therefore in this case pref gel or DTA, preparation of the roots and application of enamel matrix derivatives, and again chronically advancing the tissues in order to try and achieve, knowing that again predictability in this case will be much lower because of the position of the teeth, because of the lack of the same amount of bone, fixed bones around it, clinical results, which again at 2 weeks following the initial assessment seem to be okay, especially if we look at the canine sides, less exciting for the lower anterior teeth, which obviously have differences also in their vertical position. And that's the reassessment, the initial of 3 months, where you can notice at least the patient is probably more confident. It doesn't want to show as much the gingival tissues, not because we've told so, but probably because she's less concerned herself that the gingival tissue would be so receded after the corrective treatment. And so by looking at her initial healing of soft tissue, you can see the palate now has gone back to normality after our grafting procedures, as well as the buccal aspects of the upper and lower teeth, with some differences, obviously, and here where our eyes and the use of the techniques might give us positive and negatives about. So a nice contour of the upper recessions, completions for the upper right and the upper left, and obviously a better or a decent resolutions of that defects on the lower left side. Nevertheless, we can see the traction still present with a potential risk here in the future of one of the frenums and some residual recessions. Obviously in the anterior region, so we know the lack of interproximal tissue would have predicted the impossible task of achieving full coverage of the sides. And so if we just were to compare the beginning and the end, after 3 fairly intensive surgical procedures, we probably felt fairly confident of having increased definitely the thickness of the tissues and have achieved the upper, the more aesthetic regions, probably a more convenient and more pleasing aesthetic outcome. On the lower, the thicker tissue with the possibility at least of having reduced the speed of gingival recession. And that is confirmed also from a stable periodontal status with still very low plaque score and gingival bleeding, and the residual recessions, which will be on the upper within the range of 0.1 millimeter, in relation to the sites that we had treated, and quickly looking at the lower. The most interesting site, obviously, is the area of the canine, where at least the initial recessions has been now contained in a better way as a good start for the future. The last assessment we had of the patients was 6 months with obviously now probably the intentions of identifying how stable the results were being. So the patient itself, as you can see, still quite healthy in the rest of gingival tissues with the lack of any signs of inflammations. And just in more details, again, the pre and the post with the 6 months tend to show a better blending of the soft tissue, in particular as we look at the initial worst sites, the lower left canine, as well as the lower anterior, where still some recession is present. Nevertheless, the patients probably feel more comfortable and confident in what she's achieved. So now, critically looking at the last summary slides defining from where we started, the type of treatment provided, I won't repeat necessarily, and evaluations, open up the questions or whether it was worth it from that point of view. The patients clearly looked at the treatment received as worth the pain to go through, especially for the palatal invasive procedures. And clearly having addressed the basic concept, the basic components of gingival recession, your hygiene, having managed the sensitivity, had increased the keratinized tissue, we could have stopped at that point as a case for management and just monitor over time. The moment we act on to try and managing the aesthetics, as part from the subjective evaluation of the treatment, and you know that there are a variety of scores that could define not just how the clinicians interpret the results, but also the patients. It's always how much we, or what techniques we're putting into place for predictability or not to achieve such a goal in a way that then is sustainable over time. Because imagining having undergone 3 invasive surgeries won't be leaving a patient very happy if 5 years, 10 years time, we are in the same situations. And that's very difficult to predict, considering that these cases might have what we would tend to call in very empirical terms a progressive form of recessions. If there is obviously a drifting of the teeth or the tissues will tend to also lose some of their tone and amount over time. But it was definitely a challenging case, and it couldn't have happened obviously if we then defined with our team a proper long-term management. So the last phase obviously will remain the most crucial one, trying to maintain the whole hygiene and the gingival health with prophylaxis, recurrent sessions, polishing, but also how we would expect that from specialist management, the patient will be able with the local dentist to maintain a gingival health status. So with that, I'd like to thank you for the attention, open for the discussion. In particular, the thanks is not just to the whole Eastman in London, but for Jason. Jason is here, so thank for him helping out in setting up the presentations. And I'll be happy to take any questions.
Thank you very much, Professor D'Aiuto. I mean, it's a terrific presentation and a great outcome. I have actually the first question was a question and also a comment.
Yes.
It also came from our chair of orthodontics. Let me start with a comment. He says, good outcome for a very challenging case. So I think I would agree with him, and I think all the audience would agree as well. He does ask a question, which he says is a 3-in-1 question. One of these difficult ones. Was there an eating disorder and or early onset osteoporosis and periodontal accelerate osteogenic orthodontics? He says it's called Wildontics. Considered seeing that it appears as if the patient has some skeletal problem.
So, as I said, it's a multiple. This is a textbook basically answer the questions type. So I would say that we can comment on the eating disorder. It's again not diagnosed from our point of view. It's quite challenging sometimes to define that at the start of the treatment. It was definitely hypothesized or suspected. There was therefore the erosion attrition component, whether only parafunctional or non-parafunctional, was for us a question that still remained open. But we monitored the case now for I think more than 12 to 18 months. We didn't notice any additional loss of tissue. There was no evidence of any other medical condition. So it's interesting the comment about osteoporosis. As such, we didn't feel the need of, in addition to the medical history, to start any investigation in terms of bone mass density, or whether that was needed. It's the question, I think, could be reversed the moment that a lot of cases that are undergone orthodontic treatment potentially would appear at the periodontist office looking, having teeth with a reduced periodontium, which we have very little history about whether there was a progressive loss maybe during that 10 or 15 years of their life, whether during the orthodontic treatment or it was to start. It's clearly probably in connection with what we would now define the reduced periodontium but healthy, so that typical phenotype which would probably follow that patient over time. And with regards to the last one, so I'd say that are probably maybe difficult to define whether, if I correctly understood the other part of the question, whether this is a particular, it's like a syndrome with a complexity, or with a variety of symptoms that tend to be combined. And so therefore where probably the orthodontics, which was aimed at restoring what might have been a malalignment or disalignment in the past, is not necessarily a causative, but it might be a progressive form of gingival recessions, or at least it would be a high risk of gingival recession. And then the answer is quite challenging, because obviously we don't know. We'll have to follow this patient for about 5-10 years and define whether, let's say, our treatment was able to stop or definitely slow down the rate of a natural progressive recession. The component of excessive brushing might have been also relevant, which hopefully we have managed at this case. But I think that question's, at least from my point of view, it's quite hard just to give an answer straight away.
Okay, so let's just take one more question. We're running a little bit late, but I think just to give Daniela Salapor the opportunity to ask this question. He says, LPRF grants have shown promising results for soft tissue remodeling. Would you consider LPRF for corrective therapy in your case?
It is true, Daniela, I think this is Daniela, that's...
Danielle, I think, yeah.
Yeah, so biological treatment, so the addition of any factors which, in the PRF, which, as you probably know, it's something like, waves that comes and goes. It was there a lot as PRP before, now it's become PRF. So anything that would facilitate healing, or the wound healing in this case, would speed up the healing and maybe reduce the chances of procedures being so invasive. The difficulty is that we don't have at the moment any evidence on comparative level or randomized level that could say that this approach, for instance, in the same management of gingival recession, is equivalent or at least not inferior. So although we do the idea that this treatment could be a way to improve outcomes and reduce morbidity for such procedures, we don't have yet larger type of trials that would demonstrate that it is in the case. So I would still leave it as a job for researchers, not necessarily for clinicians in their practices.
Okay, terrific. Thank you very, very much, Professor D'Aiuto. I had our chair of orthodontics who said that I butchered your first name, so I should try it again. He said it's Francesco.
Francesco, indeed. I mean, you managed to get my surname right, Cyril. I mean, it's almost like my heart is bleeding, because after 20 years of hearing it in any possible shape or form, I have to commend you. Used exactly the same right pronunciation. But Francesco.
Well, I'm pleased that you managed to say that, because our chair of prosthodontics, Carlo Ercoli, is now going to have another voice on this issue. So Carlo, be aware, I have somebody else to support my translation. So I want to thank everybody very much for absolutely excellent presentations. What a terrific 3 presentations were given. The questions were interesting, and it's a great signal that this collaboration between our 3 institutions is both worthwhile and I think has additional significant possibilities. So thank you again, and we look forward to our next Eastman International Alliance Grand Rounds, which will be held in September, and we'll be sending out information about that. I want to remind people that there is a poll for you to complete at the end of this. It's coming up on the screen right now, and if you go ahead and complete that, that'll help you to get your CE credits. So thank you very much, everybody, and I appreciate your participation, and Ciao and bye. Thank you.
Thank you very much.
See you next time. Thank you, Carolina. Thank you, David and Elian. Bye now. Bye.
Bye.
So for the rest of you, if you want to complete the poll, go ahead. We'll leave it open for you to be able to do that.